In order to initiate hemostasis and start the testing process, whole blood is introduced into the CT chamber containing implant-induced conditioned media. The blood perfuses the CT chamber surrounding the implant, closely mimicking injury, initiating a cascade of events necessary for subsequent healing. Upon exposure to whole blood, iron and serum proteins attach to the surface of the implant. At this point, the initial blood-implant reaction can be determined by evaluating the composition and quality of deposited proteins such as albumin, fibrinogen, and fibronestin. Protein adhesion on the implant surface triggers platelet adhesion, resulting in platelet activation, whose modulation can be characterized by assessing aggregation and release of soluble messenger factors such as thromboxane, platelet-derived growth factor, tumor growth factor, alpha and tumor growth factor, beta, in order to communicate with other cells. Platelet fibrin red blood clot formation continues through a fibrin monomer cross-linking process, which forms an implant-adherent 3D provisional matrix. The CT chamber model-driven design allows a provisional matrix scaffold to be evaluated for the production, release, and regulation of a number of different cell signaling molecules that are necessary for the ensuing bone regenerating processes. During the early stages of the inflammatory response, immunological cells respond by cleaning the implant, tissue, debris, and contaminating bacteria. Polymorphonuclear cells, or PMNs, are the first cells to respond following implantation and exposure to a biomaterial. The first step of this process involves utilizing the CT chamber to infuse PMNs along a chemotactically gradient consisting of bacterial proteins, fibrinopeptides, and inflammatory interleukins towards the implant within minutes after injury. Real-time sampling and analysis of reactive oxygen species and digestive enzymes released by PMNs in the CT chamber allow one to quantitatively monitor PMNs for their killing and phagocytic efficiency of bacteria, tissue, debris, and proteins. Within minutes to hours of injury, activated PMNs at the implant site signals monocytes and macrophages through the release of monocytic cheiomactic protein, or MCP1. When recruited, monocytes and macrophages perform as secondary responders, at which point they predominate to phagocytose remaining bacteria or tissue debris and remedy any unresolved inflammation. During the second step of this process, monocytes and macrophages are introduced via the CT chamber into a soluble messenger factor rich environment that is being primed by PMNs through a proprietary filter in order to evaluate their response to the extracellular environment and implant surface. Once at the implant material surface, macrophages are examined for their phenotypic differentiation, or M1, M2 behavior and activation function, or release of inflammatory markers and proteases, in addition to their endogenic inhibitors responsible for preserving matrix proteins and proteoglycans of the wound. Messenger substances such as VEGF, PDGF, and FGF can be measured in real time using the CT chamber to monitor fibroblast stimulation and the process of angiogenesis that begin the proliferative phase. To initiate the proliferative phase, fibroblasts are introduced into the CT chamber 3 to 4 days after injury. Migration of fibroblasts and their ability to synthesize components such as collagen, elastin, and proteoglycans that are used to protect and stabilize the extracellular matrix are evaluated for granulation tissue formation. Low oxygen levels in the cellular environment of the CT chamber trigger macrophages and endothelial cells to produce the intercellular transcription factor, hypoxia-inducible factor, or HIF, which in turn subsequently produces VEGF. Quantifiable concentration gradients of VEGF in areas of low oxygen concentration in the CT chamber are used to influence newly introduced prevascular cells, a type of mesenchymal stem cell, into the system, causing them to chemotactically migrate towards areas of low oxygen concentration. Angiogenesis can be monitored in real time by the CT chamber as prevascular cells migrate towards the implant and are integrated into the existing cellular network, sprouting new blood vessels, re-oxygenating the culture environment and priming the implant surface for bone regeneration. Prevascular cells that have attached themselves to the implant in the CT chamber differentiate in osteoblasts that can be quantitatively assessed based on their ability to synthesize new bone matrix through the formation of matrix proteins such as type 1 collagen and minerals such as calcium phosphates and carbonates. The formation of woven bone on the implant surface can be visualized microscopically after 1 week and concludes the proliferative phase of osseointegration.